No. Okay. Ask.
Okay.
Okay, because somebody else here said they didn't know where it was, asked the tech, and the tech didn't know where it was. So on the GE, it's clearly displayed. You have your TR, you have your TE, you have your TR, you have your flip angle, and then you have your TI. So it's clearly there. Okay, on Philips. Do you see where your inversion time is?
Yeah, I just put one of the tabs off.
Okay.
Yeah, I think that's the.
It's important that you guys know where these parameters are.
I think on the GE, I think it's on the like sequences or something like that on one of the other tabs. And the Siemens. Yeah, and then it's like where the attenuation and all that stuff is. I think it's on.
Okay, that's what I had said. I thought maybe all you had to do was go under the sequence tab, and as long as you're selecting flare or stir, it will set your TI. Because typically we don't mess with the TI. The TI, remains the same, but you have to know where it is. Okay, to make sure that it's obviously set properly. Okay, so if we want to do a stir, our inversion time will be what? Short. If we want to do a flare, long. Why? Nulling, I like that. I'm not making fun of you, I like it. I didn't say that. So, remember, it all goes back to what? T1 and T2 times of fat and water, right? So the T1 and T2 times of fat are always, so if we want to null fat, it's going to be a short inversion time. If we want to null water or fluid, it's going to be long, okay? It's all there, guys, so we're pulling it together, okay? Questions? Questions. Make sure you guys are looking at, when you're scanning, you're seeing your parameters. And again, they're clicking, and they're changing, and they're moving things. You guys now have a better understanding of what our parameters do. Okay? So if you see them click that on the matrix, you see them change that phase matrix, drop it down. What are they doing? What does dropping your phase matrix do?
Cut the time.
Cuts your time. What else does it do? It increases your signal. Okay? The biggest thing there to text, your time. Okay? And it's a plus because now you're gaining signal. Okay? If you see the text, flip it around with your necks. Which way are they most likely playing with the necks? Why?
Decrease your time.
Right. Okay, but what happens when that happens? When you decrease your necks and you decrease your time, you're losing signal. Okay? This is what we're putting together. Okay? Your frequency matrix. Have you seen the text play with the frequency matrix? Not usually. Not usually. You can drop your frequency matrix. Let's say your protocol has 320 at 256. You can go in there and you can drop your frequency matrix down to 288, and it's not going to hurt your signal. Okay, you're not going to gain any signal, but you're not going to hurt. You're not going to lose any signal either. You will cut just a teeny tiny bit of time. Okay, but the main parameter there in matrix, if you want to cut time, is your phase matrix, because not only will you decrease your time, but you'll increase signal. Okay, typically you won't play with your necks. What does next control? What does next do? NSA, number of signals average, number of excitations. What does that do? How many times? What fills each line of K-space? Your phase matrix, right? That fills each line of K-space. How many times each line of K-space is controlled by your NEX or your NSA? Okay? So if you increase your NACS or your NSA, you're increasing the amount of times K-space gets filled, which will increase your signal, but it also will increase your time, okay? Your TR, when would you play with your TR?
When the patient's
When?
claustrophobic.
No.
Depending on your slices.
TR controls two things.
Nice.
Numbers, number of slices, right? And your T1 contrast. So when would you play with your TR? Only if you don't have enough TR per slices selected, okay? You have to be careful though, remember, if you're bringing it up because you added slices, if you're doing T1, you have to watch those numbers because if you bring your TR up too high, what will happen? You will diminish your T1 and you will be pushing towards a proton density. Okay? It's coming together, right? Coming together? All right.
The echo train length.
Echo train length, yes. What does echo train length, what does that mean? What's the definition or what is it?
The number of 180.
It's the number of 180 rephasing pulses.
After the first 90.
Correct. So it's a parameter used in what pulse sequence, what type of sequence? Fast spin echo, right? Spin echo is what?
180.
90, 180, 90, 180. Fast spin echo is 90, multiple 180s, okay? So what's your question, Sheree?
Because I got it wrong. It says which one has more weighting average, and the answer was T1. I put T2 because how is that? I don't know how.
What was the question? Read the question.
It says using a longer ETL will have more weighting average and become more of a concern for which pulse sequence.
T1.
Why? Why T1? Okay, let's go back to a fast spin echo.
Because it mentions the TE and then gives.
A fast spin echo, when you have multiple 180s, your TE becomes
Average.
an effective TE. So it's not the exact TE that you set.
Right.
So the system will take an average of all of the TEs that get run each 180.
But TE
The more one,
T2. That's what
it does.
okay.
The more 180s you have, the more of the wrong TE, we'll say wrong TE, will come up. Okay? So what happens? TE controls what? T2. So if you're running a T1 fast spin echo and you raise your echo train length way up,
Right.
your TE is going to be all over the place. What do you need for a T1 weighted image for your TE? A short TE. So what happens, let's say we have an echo train length of 10 and we set our TE at 25. It's going to go from under 25 to 35 to 40. What happens as that TE goes up?
It becomes more of a proton density in T2.
Okay, so remember, echo train length is very important. When it comes to T1, you need to keep that short. Remember, do they remember the number that I used?
Less than 4.
Right. Because you want to keep that averaging of the TEs at a minimum.
Okay.
Okay, does that make sense?
Okay. Yeah.
Good question though. So what else happens with a fast spin echo with your echo train length? What else does the echo train length affect?
Blurring.
How?
Because of
The more T
more
train
and
echo
it's like
train.
averaging the TE, so it's not really true what you
Right.
so
So as you increase your echo train length, you increase the chance of blurriness, because as each line of K-space gets filled at that different TE, again, more of the wrong TE is going to be sampled, and it's going to bleed into the next one. So it's going to be, that will cause that blurriness. Make sense?
And the other hand, we decrease the time.
As you increase your echo train length, yes, it does decrease your time, but again, you have to be careful because now you're increasing that blurriness. So for a T1 fast spin echo, we want to keep our echo train length short or 4 and below. For a proton density, where should our echo train length be?
Medium.
7 to 10, and then our T2,
10 and 11 above.
yeah, 12, 25, anything above 12. But again, be careful, as you increase that echo train length, you're going to increase the blurriness. We usually run ours at around 18, 16 to 18. Okay, 14, did you say? That's what you guys were doing? Okay, so again, I'm stressing, when you guys are behind that, when you're driving, when you're behind the mouse, even if you're sitting and watching, look at where those parameters are and watch what they're doing. See what difference, like I know the GE on the bottom, it gives you what happens to your signal. I believe Philips and Siemens.
According to my experience, if you don't mess up with the parameter or set in the computer, you get better result. And you get it on faster.
Pretty much, yeah.
So,
Yeah.
and I guess kind of do this.
In a perfect world, yeah, to sit down and run, I'm guilty. I'm guilty of it, you know. We get behind, and I know where I can shave and not suffer, suffer image quality. So I know I'm not the only one that ever runs behind, but there are some techs out there that they want to get it over with quick.
And then they have to repeat at the end some sequences because they mess up some sequences.
The old saying, haste makes waste.
Oh my God,
All right. So we're feeling good, though, about parameters and where we are to this point. Yes? Everybody's feeling good? All right, so the next couple of weeks, month and a half, we're going to cruise. It's going to be pretty easy. We're going to go over anatomy, not anatomy like you did with your cross-sectional, but we're going to go over scanning parameters, like where to scan from here to there, what to cover, indications for exams, these things, all kind of, they're important. The 20th, February 20th, which is 2 weeks from tonight, there will be no meeting here. I'm going to say most definitely, I'm going to post the test. We're going to do head and neck tonight, chest and spine next week, and then the following week, I'll post the test like I did this past, last week from 6:30 to 8:30. Okay? I'm going to concert 1 out of 10.
Nice.
Which concert are you going?
So mark that down. The 20th, no class, but I'll do the test online. Okay? No more questions? We'll get started with head and neck. Good? All righty. So we're going to talk about scanning protocols and different techniques. I know we've kind of touched on this briefly before. Patient comes in, they have a history of trauma, and they fall, they hit their head, they're in for an MRI of the brain. What sequence would we run? If it's not already in your routine protocol, what would you run? Extras. Why? For blood. Why? Why would a gradient? But why?
Gradient doesn't clean up the
Very good. Okay, so these are the kind of things we're going to go over. We're going to talk about, different sequences to add when we have, when we get histories and things that start thinking on our own. in case your facility doesn't have, this is a protocol for MS, this is a protocol for trauma. Where I'm at, on my brain protocol, I have the routine, and then anything that's extra, I put a little asterisk next to it. So if the patient has history of MS, boom, we're going to put in a sagittal T2. If the patient has a history of blunt trauma, like car accident or something, like being in the outpatient world, we do a lot of PIP stuff, and they'll order what's called an SWI. And that is, it's a gradient echo. It's basically just a gradient echo, but it's very, very thin slices. Okay, so just things like that is how my protocols are set up. So you have to know your histories, and you have to know what to look for and what to add once you get a history. All right, so let's talk about exams that we're doing on the head. We do a routine brain, temporal lobes. What do we do temporal lobes for? What?
Seizure.
Seizure, very good. So these are the things we're going to bring out, okay? Posterior fossa, or IACs, right? What do we do for posterior fossa IACs?
Acoustic neuromas.
No, what do we do for it? What kind of sequences do we do for it is what I'm saying. We're going to do thinner slices, right? Because the IACs are much smaller structure, okay? So my facility, we do what's called a fiesta on the GE, and basically it's a gradient echo. It's a T2 gradient echo. It's a special sequence that GE calls it fiesta. Other systems may not call it that, but it is. It's a very thin slice. It's a 3D. What's the difference between 2D and 3D? What did you say, Santana?
Pixels.
3D is wide.
We can scan a sequence as a 3D. We can scan as 2D. What's the difference?
Well, I know the 3Ds have, there are a lot of slices and they're very small.
Come on, Mike, you know the answer.
I know, I forgot that.
I know Dale taught you this.
Yeah.
Does it use all three gradients?
When you set up regular axials for a brain, right? Those are 2D. How are they set up? When you look at your screen, what do you see? Oh, you see line, line, line. Each line designates the slice where it's going through, right? When you do a 3D, it's what's called a slab, okay? You can't set slice 1 here. You know what I'm saying? You can't take it. You have to take that whole box and center it over your anatomy. 3D is acquired in a volume or a slab, meaning anything that's in that block, in that slab, in that volume, is excited at the same time. 2D gets acquired slice by slice. Okay? So, if you're doing, like when you do the axial, let's say you're doing the axial T1 of the brain, and you have 20 slices. If you perform all 20 slices in one acquisition, or for you Siemens, one concatenation, right? When do you see your first slice? Think about it. When do you see your first slice? When it's all finished running. Why? You did it in one acquisition, and it's acquired slice by slice by slice, right? When you do a volume, when do you see your slices? When the volume's done, because all of those, everything that's in that box gets excited at the same time. So let's go back to the brain, 2D. We're doing it in 2 acquisitions now. When do you see your first slice? When is the first acquisition done? Halfway through. So let's say you have a 3-minute scan, and it's done in 2 acquisitions. After a minute and a half, slices 1, 3, 5, 7, 9. Have you noticed this? Okay, that is what? if you do it in one acquisition, slice by slice, 2D, you won't see any slices until the entire 20 slices are completed, until that scan is run. If you do it in 2 acquisitions, you will see you'll see every other slice come up halfway through the scan. Make sense? All right, so that got a little off base, but anyway, these are the different types of routine, or the different head scans that we do. Routine brain, temporal lobes, as we said, for seizure, IACs. We're going to talk about the different indications for each one. Pituitaries, orbits, and sinuses. Okay? Is that better?
Sorry.
Okay. So, head exams, positioning. Obviously, you want to try to get the head as straight as possible, and you're going to landmark at the glabella. Okay? Head, again, in the perfect world, the head's going to be perfectly straight. We have some of those patients that are like this, you know, they do the best that you can do. Okay? All right, so common indications for routine brain. We've got tumor, a mass, METs, meningioma, MS, AIDS, infection or abscess, hydrocephalus. You'll see all of these different types of diagnoses on a prescription for someone coming in for an MRI of the brain, okay? What we do with these is going to be our learning curve here, okay? So like a tumor, if you see someone, prescription, and it just says MRI brain, diagnosis, mass, tumor, what would you do?
Contrast.
Definitely contrast. Why?
To highlight the tumor or the area itself, because it'll have vessels.
Correct. So you want to take that prescription and you want to make sure that you have an order for with and without contrast. If you have a prescription for a patient for MRI brain without, and their diagnosis is mass or tumor, question it. Okay, yeah, definitely question it. These are the things you guys are going to have to start looking for. Meningioma should also have contrast. Okay, what is a meningioma?
It's a layer of the brain.
Right. It almost looks like an ADN. Okay, it looks like a little ball. Okay, they're best seen with contrast. MS. What do we do for MS? We routinely do an axial flare. We're going to add a sagittal flare. Very good. Patient has history of AIDS or toxoplasmosis. What are we going to do? We're going to do contrast. Okay, we want to do contrast because typically we're looking for a mass. Okay, infection or abscess. Again, contrast. These are the things we need to know so that we can make sure that the patient gets the correct exam that they're supposed to be getting. Hydrocephalus.
It's contrast. It's an infection.
No, hydrocephalus is not an infection.
Yeah, it's an accumulation of fluid in the...
Right, so you don't necessarily have to give contrast. Okay? Trauma. What do we do for trauma brain?
You can run a hemo.
Or gradient. Seizures. What do we do for seizures?
What? Temporal.
Diffusion.
So temporal lobe.
No, it's not for seizures.
So temporal
It's-
lobes.
But what? No,
It's a small.
coronal.
small
Coronal, T2, through the temporal lobe. Okay? TIA, CVA, infarct. What are we doing? What are we running? No, you said it first.
Those are stroke.
Right. So what are we doing? Diffusion. That should be right. That should be routine, but it didn't used to be. It didn't used to be routine. We used to only run them on CVA patients, but when they got perfected down to a minute, less than a minute, it's stupid not to do it on every patient. Does a 16-year-old that's in there for headaches really need it? No. but it's less than a minute long. Run. Neurological symptoms. Acute hearing loss. What do we do for acute hearing loss? ICs. Visual disturbance. Orbits. Slurred speech. Slurred speech.
Diffusion.
Goes back up to diffusion because slurred speech can be stroke, right? Facial or extremity numbness. Again, the diffusion. Okay? We got this, right? All right, so these aren't Bible, these aren't set in stone. This is just recommendation. Most places, you're always going to run a sagittal T1, an axial T2, an axial flare. Used to use a proton density, not so much anymore. Then you're always going to do axial T1 pre and post. Why do we do T1 post? Why?
Because the contrast shows different on the T1 with the fluid.
Why? What does gadolinium do?
Highlights.
No, you're close.
Effective.
It shortens the T1 time of the tissues. Okay? So giving gadolinium and doing a T2 post contrast, it's not going to make any difference. Okay? So gadolinium shortens the T1 time of tissues. Therefore, we do T1 post contrast. Sure.
Is a PD pretty much interchangeable with a flare at any time? Because I remember I was talking to on the test.
Yes, before they really perfected the flare, we used to always do a proton density. Who remembers the dual echo? We talked about dual echo. What's a dual echo?
1 T or 2 T.
Very good. And what are the two image weightings that we get from a dual echo?
Proton density in T2.
Why?
Because of the two
You get a
T.
proton density.
And a T2, but why? Why can't we get a T1 and a T2?
Because the TR is
Because of the TR. The proton density, which is right in the middle, has a commonality of the long TR, right, with the T2 and the short TE of the T1. Okay, so we can use a long TR and get a proton density and a T2, and we just have to use two different TEs in order to get proton density and T2. Make sense? So we also do a coronal T1 post. Again, T1 because gadolinium shortens the T1 time of the tissues. Your setup for your sagittal, obviously you're going to set it up off your axial or your coronal. This is not going all the way through the brain. This is just showing you that that's the sagittal. It's cutting left to right. So when you look at these, don't think, oh wow, that's all you covered. No, you need to cover the entire brain, okay? But this is what it should look like, or does look like on your axial T1 and your coronal. And then here's your axial setup on your sagittal, and your coronal setup on your sagittal. This is easy stuff, right, guys? We all already know this. Okay. What did you say?
No,
Oh, okay. So special considerations, which we actually went through each one of them. Diffusion, you're going to use for CVA, trauma, or seizures. Additional flare sequence for MS plaques. Pediatric brain, for those of you, there's only a few of you in here at St. Mary's, right? You got St. Mary's? No.
No, it's just me.
It's just you? Okay.
No, we just all three work at St. Mary's, that's all.
Oh, gotcha. So are you mainly on the 3T or are you
I'm on
outside?
3.
So you're not outside doing the anesthesia cases on
No, we do
kids?
we do anesthesia cases on the 3 too.
Oh, now you do,
Yeah.
okay.
Yeah, we do a bunch of sedates.
Okay,
Sometimes we have like 5.
kids, you do kids?
Oh, tons of kids.
Okay,
All sorts of kids.
so then this should really peak out for you. The rest of us here, we don't do peds. We're not an outpatient center, we are not equipped to
We
do,
do the NICUs also sometimes.
yeah, we're not equipped to do that. Pediatric brain, T1 weighted IR inversion recovery sequence will best demonstrate differences between gray and white matter. Okay? So your inversion time will fall around 700 milliseconds. This is for a pediatric brain. You want to add a T1 weighted inversion recovery with an inversion time of around 700 milliseconds. I believe this question is on the board, so just I'm going to put a little asterisk next to it, okay? It might state, like, when scanning pediatric brain, which sequence should be added or will show the difference between gray and white matter, okay? T1 weighted inversion recovery with an inversion time of around 700. Mag transfer. We talked about this briefly. So magnetization transfer, or MTSAT, is an imaging option. Okay, it's used on post-contrast axial T1 sequences. I know we went over this before. It helps to increase the contrast between normal and pathological tissue. It helps to distinguish mets and low-grade tumors from normal tissue, and your gray and white matter lose about 30 to 40% of their signal when a magnetization sat is used. So it emphasizes the tumor signal. Okay, it takes a regular gray and white matter and it will reduce the signal coming from it to help emphasize the tumor signal. Okay, so basically all you guys need to know is mag transfer is used on your post-contrast, obviously T1 weighted images. It helps to reduce the signal from gray and white matter, normal gray and white matter, 30 to 40%, to emphasize the tumor signal. How many of you know where your imaging options are on your system? Okay, look for these things.
Like you mean as far as the scan protocols?
On your scanning page. What are you scanning on Siemens?
Yeah.
Okay, so you should have an imaging options page. Imaging options include, does anybody know what you would look for on there? Ben, what would you look for on your imaging options page?
No phase wrap.
Very good, no phase wrap. What? Arc.
That's for resolution.
No, that won't be under imaging options. I know what you're talking about.
Well, okay.
Yeah, that's under a different.
Well, I have a button that says imaging options. And
Right,
then it's
there's
listed, like check marks, and we have no phase wrap on there. But we also have, there's art, there's some other stuff.
Yeah, those are a little bit more advanced ones. You'll find mag transfer. Ben, are you on GE?
Yes.
Okay, so what system are you on? What are you on, 450W?